All right, well, welcome everyone. Thank you for joining us on our AIDS View Health Disparities in HIV webinar. My name is Dr. Amanda Castell, and I'm a scientist here at AIDS View. And I'm also a professor in the Department of Epidemiology at George Washington University. So today we are going to discuss the importance of looking at disease burden through the lens of health disparities. We're going to talk about some practical applications for using social determinants of health data to target and tailor programmatic interventions, and talk about how social determinants of health can be used in research and analyses, and the social determinants of health tools and resources available to you on AIDSView. As a quick note, we are recording this webinar, and so we will be sharing it in the coming days. We recognize that many of our colleagues are very busy with the COVID-19 response, and so we want to make sure that this webinar is available for them, and in case any of you want to share it with your teams. And we just want to take a moment on behalf of AIDSView to thank everyone for the hard work that they're doing to address the pandemic. So joining me today are Dr. Kathleen Brady, who's the Director of HIV Epidemiology for the Philadelphia Department of Public Health, as well as Dr. Carlos Rodriguez-Diaz, who's an Associate Professor and the Director of the Community-Oriented Primary Care Program, also a colleague of mine at the Milken Institute School of Public Health at George Washington University. And we'll hear from them shortly. So first, I'm going to give you a quick overview of AIDSView. I know many of you all are already familiar with the work we do. Then we'll quickly walk through what we mean when we talk about health disparities and social determinants of health and why we think they're important. We'll dive into some of what the social determinants of health data, maps, and resources that we launched in December look like, followed up by some of our insights. And then I'll turn it over to Kathleen to talk about how she's using social determinants of health data and AIDSView data in her program planning. And then Carlos will discuss how he recently used some of the social determinants of health data that are available on AIDSView to conduct an analysis that compared these data against COVID-19 data, analyzing disease burden among specific races and ethnicities. And then finally, if time allows, I'll finish up with just showing you some quick other AIDSView resources, and we'll certainly have time for a Q&A. When we do open it up for the Q&A, please feel free to add your questions to the Q&A box, and you'll see it in the Zoom toolbar at the bottom of your screen. So let me start with a quick overview of AIDSView. So AIDSView is presented by Emory University's Rollins School of Public Health in partnership with Gilead Sciences and the Centers for AIDS Research at Emory University. And here at AIDSView, our goal really is to make data widely available, easily accessible, and locally relevant to inform public health decision-making. As many of you know, the United States has one of the best HIV surveillance systems in the world, but for many of us, the data sometimes have limited utility because it's usually generally available through what can be perceived as dense reports and spreadsheets. And so the beauty of AIDSView is that we are able to take that data and really, in a, we think, a usable and feasible manner, collect that data and visualize it in a way that's intuitive and can tell a very powerful story. We hope that policymakers, advocates, health departments, researchers, and other experts and stakeholders are able to use our tool to educate the public, other stakeholders, to use it to advocate for critical issues and strategically allocate resources and plan programs. So in summary, we are empowering people to end the HIV epidemic in their community by visualizing data, presenting these insights, and catalyzing research to drive public health action. We're proud to say that AIDSView is now 10 years old, and it has come a long way in that 10 years, in that decade. We started with state level data from CDC. We moved on to gathering county level data, and then to city level data. And we are constantly pushing to get more granular data as we continue to evolve. This year, we presented and released the first ever county level data on PrEP use. And now we've also added data on the HIV care continuum and more social determinants of health data, which of course we're talking about today. But again, by constantly improving the data and the granularity of the data, we hope to be providing our stakeholders with a more comprehensive view of the HIV epidemic, both at the local, state, and national levels. And so at the end of the day, really the goal of AIDS View is to help you understand HIV where you live locally and to be able to use that data in a meaningful way. So I'm going to switch gears and talk about health disparities, social determinants of health, and HIV. So I want to start by making sure we all have a common understanding of what we mean when we talk about health disparities. So here's the CDC definition of health disparities, which they say is differences in the incidence, prevalence, and mortality of a disease and related adverse health conditions among specific population groups. And they go on to mention that those groups might be characterized by gender, age, race, ethnicity, education, income, social class, disability, geographic location, or sexual orientation. But needless to say that addressing these disparities in health is really important in order to increase health outcomes amongst a broad population, to reduce healthcare costs, and to achieve equity. So we feel that if we're going to end the HIV epidemic in the United States, it's really essential to understand why HIV has had a disproportionate impact on certain populations, and to understand the drivers of those disparities at the local, state, and national level. CDC also has a standard definition for social determinants of health. Here they define it as conditions in the places where people live, learn, work, and play that affect a wide range of health and quality of life outcomes. And we know that social determinants of health are really a complex set of factors that can maybe at the individual, the provider, the health system, societal structure, even location level, but all contribute directly to health outcomes and health disparities. And you can see here in this figure from Kaiser Family Foundation that a combination of poor social determinants of health and identity related experiences can often lead to poor health outcomes, including inadequate HIV prevention and care for an individual. And so while these disparities are not exclusive to HIV, we really do think that they should be considered in all of the work we do around research and policymaking and advocacy in order to really target our programmatic interventions and resources for those who are most affected. So in summary, social determinants of health, including poverty, unequal access to healthcare, lack of education, stigma, racism, are all contributors to health disparities. And we know that in order to improve health outcomes, we need to reduce those health disparities. Interestingly, in the new HHS plan to end the HIV epidemic for 2021 through 2025, one of the main goals of the plan is to reduce those HIV-related health disparities and health inequities. And the plan actually states that the US should be a place where new HIV infections are prevented, everyone knows their status, every person with HIV has high quality care and treatment and access to those services, and that they're living free of stigma and discrimination. And that should be regardless of many of these factors, whether they're demographic, religious, sexual orientation, or geographic. So in keeping with AIDS View's core mission, by visualizing data across these social determinants of health, we are really better able to identify disparities in outcomes, develop these programs, and allocate resources to address disparities in a variety of different communities. And so by being able to visualize where we see overlaps between HIV prevention or prevalence, for example, and where there are social determinants of health that maybe are not, or that are inadequate, such as severe housing, for example, we are able to support people to develop policies to really improve these outcomes. And so these two maps here show you a good example of where we need to see systemic change. So you can see that the rates of persons living with HIV are higher in the darker red and orange colors, and they seem to overlap with the proportion of people living with severe housing, with a severe housing cost burden in the darker purple. So how we use these data to try to develop some insights around health disparities. So AIDSView has gathered the social determinants of health data from the American Community Survey, as well as using other data sources, but primarily from the ACS. AIDS View, as many of you know, provides these interactive maps of social determinants of health indicators that can be viewed alongside maps of HIV prevalence or new diagnoses, HIV mortality, the care continuum, or PrEP utilization. The social determinants of health indicators are listed here. I won't read all of them to you, but you can see that we are able to really get pretty granular in terms of being able to look at food insecurity, housing, Medicaid expansion, unemployment rates, in addition to other things like median household income. One of the nice things and features of AIDS View that's very intentional is that not only are the data available on the website, but you can actually download them for your own use as well. And so to find out more about how you can use these data, if you go under our tools and resources section of the AIDS View website, you click data sets, you can filter down and find the year of data that you're looking for and actually download certain data sets in an Excel file. We also have just published a protocol paper describing how AIDS View was put together and how all of the data and visualization resources are available to you, and the citation is listed here on this slide. So I want to go over some of the basic social determinants of health statistics that we have available. This graphic shows you quite a few of them. I won't go over all of them. I do think just contextually, because we are living in the midst of this pandemic, it's important to note that these numbers are reflective of certain situations and health determinants before the COVID-19 pandemic. So for example, you can see in the top left corner that while 13% of the US population is living in poverty, 23% of Black people are living in poverty. Or that if you look at uninsured, while 10% of the US population is lacking health insurance, we see that the rates are almost 2 times higher among American Indian Alaska Natives and Hispanic or Latinx people. And then again, if you look at household income, for example, the median household income for the entire United States is around $61,000, but significantly lower for American Indian, Alaska Natives, and Black people at less than 45,000. So these are just some examples of the basic statistics that are available around social determinants of health. Here's an example of one of the many maps available highlighting these disparities. So this one shows you that in 2018, of the top 10 cities in the US with the highest rate of people living with HIV, 6 of these were also the top 10 cities with the highest burden of people living with severe housing cost burden. Next slide. And then if you look at structural level social determinants of health, about 40% of new HIV diagnoses in 2018 occurred in 12 US states that have not adopted Medicaid expansion. So again, clearly a structural level social determinant that needs to be addressed. And then here's another example highlighting the disparity between linkage to HIV care and food insecurity. So between 2016 and 2018, in the 10 states with the highest level of food security, 77% of people diagnosed were linked to care. But if you compare that to the 10 states with the lowest level of food insecurity, almost 85% of people were linked to care. So definitely we see that relationship between linkage to care and food insecurity. And then finally, this map shows the relationship between viral suppression and unemployment. So while in 2018, in 10 states with the highest level of unemployment, 61% of people were virally suppressed. But in comparison to the 10 states with the lowest level of unemployment, as many as 68% of people were virally suppressed. So hopefully I've shown you some of the data that are available on social determinants of health on AIDS View, and highlighted some examples of how that's adding to our understanding of health disparities and their impact on HIV outcomes. I'm now going to turn it over to Kathleen and then to Carlos to provide you with examples of how they're using these data in their programming and research. So Kathleen.
Hi, good afternoon, everyone. So today, actually, why don't we go to the next slide? So today I want to discuss how AIDS View can be used to visualize where programmatic interventions are needed most. So over about the next 5 to 10 minutes, I'm going to go through some examples that hopefully will get folks thinking about how they can use data at the national, state, and local level for structural change. Let me go to the next slide. Okay, so let's talk about an important topic that Amanda has mentioned, and that is hunger and food insecurity. So food insecurity in people living with HIV has been linked to adverse health outcomes, including poor antiretroviral adherence, poor HIV viral suppression, frailty, and mortality. So another study released at ID Week from some colleagues of mine at the University of Pennsylvania have found that increased access to SNAP, the federal nutrition program, was associated with decreases in HIV diagnosis. So what we see here on the left is the rate of persons living with HIV in 2018, and on the right, the proportion of populations living with food insecurity by state. So unfortunately, what we can see here is there's significant overlap, mainly in the southern United States, where there's not only high rates of people living with HIV, but also high rates of food insecurity. And so these are areas where increased access to SNAP benefits could have significant impact on outcomes for people living with HIV and help meet goals of EHE. Why don't we go to the next slide? So one way that I use AIDS View is to visualize insurance coverage to identify areas where PrEP programs need to consider support by PrEP DAP programs. So on the left is the rate of persons using PrEP in Georgia by county, and on the right is the percent of the population lacking health insurance coverage. PrEP coverage is lowest in some of the rural counties of Georgia that also have the highest proportion of the population lacking health insurance. These areas are places that may need support from those PrEP DAP programs. You can also use the locator information that's available on AIDS View. So you can look for counties that have no PrEP providers and basically improving access to PrEP in counties that have low usage of PrEP, high uninsured rates, and no PrEP providers. It could be a planning priority. Why don't we go to the next slide? Lack of stable housing and homelessness is another factor that leads to poor outcomes along the HIV care continuum. So here on the left, we have rates of people living with HIV in Atlanta by zip code, and on the right, the proportion of the population living with severe housing cost burden, similar to what Amanda showed at the national level. Once again, we see that there's significant overlap. Unfortunately, you can expect that people living with HIV in these areas of overlap are going to have higher rates of housing instability and homelessness due to the high cost burden of housing. So targeting additional housing resources in these areas could lead to potentially improved HIV outcomes. Why don't we go to the next slide? And so here we have data from my home of Philadelphia. So these are the same graphs for Atlanta. And so once again, we see that there is significant overlap between the high rates of people living with HIV and high housing cost burden by zip code in Philadelphia. Unfortunately, severe housing costs are a major problem for the majority of Philadelphians and not just people living with HIV. So this is really a difficult issue to tackle from the HIV side of things in Philadelphia. It is something that we need to collaborate with multiple organizations to hopefully impact HIV. Why don't we go to the next slide? So now I want to focus a little bit more on how AIDS View can help you understand the communities at risk for HIV. So on the left, we have the rate of new HIV diagnoses by zip code for Atlanta, and on the right, the proportion of the population that only have a high school education. So the zip codes with the highest rates of new diagnoses are in Atlanta are also the same areas that have the lowest percentage of individuals with a high school education. And so this really highlights that the need for HIV education materials meet the reading level of the population most impacted. And why don't we go to the next slide? And so now we're back to Philadelphia and we see the same story. And so once again, we need to ensure that education materials meet the needs of those at risk from becoming infected. And actually this is something that is a local priority for our EHE plan in Philadelphia. And that is really to be able to have really a patient bill of rights and toolkits for patients that are in plain language so folks can understand what their rights are as individuals living with HIV in Philadelphia. So that's something that we hope to have available soon. Why don't we go to the next slide? And so for this last example, we really wanted to show some data at the census tract level. So Philly is known as a city of neighborhoods. And so census tract level data doesn't always tell the full story. And so looking at social determinants of health at the more granular level is really helpful for planning purposes. On the left, we have the rate of people living with HIV by census tract. And on the right, the proportion of the population that is living below poverty level. And so looking at census tracts with high prevalence and high rates of poverty overlaid where our locations of our Ryan White funded clinics is helpful to determine where there may be gaps in care services for people living with HIV and where the health department may want to allocate care resources in those areas. Right. And so why don't we go to the next slide? And that's actually the end of my presentation. So now we're going to move on to Carlos Rodriguez-Diaz, who's going to talk about utilizing AIDSview social determinants of health data and analyses. Thank you.
Thank you, Dr. Brady. And thanks for the opportunity to join this webinar and share the experience of using AIDSview data for research purposes. And as many of you know, the COVID pandemic has disproportionately affected Latino Hispanic communities in the United States. And that's very similar to what we've seen and continue to report is the case for the HIV epidemic. Early in the process or the experience of managing the COVID pandemic in the United States, we noticed how certain disparities were evident. But the truth is that for many of us, we knew that there were structural factors that could predict what we were seeing in terms of having more Latinos and communities of colors disproportionately affected by the pandemic. And here's some of the headlines that we saw in the first 6 months of the pandemic. And we had very limited evidence to support the impact of structural factors. And further, we needed information to provide to local governments and federal agencies to tailor the strategies to address the disparities that we're seeing in communities of color. Next. So inspired by the work of Greg Millett and many scientists known in the HIV field, we conducted an analysis to identify the risks for COVID infection and COVID deaths among Latinos in the United States. And this study is actually already published. It was published the second semester of 2020. And it's based on data that was available in the first 3 months of the pandemic. So please keep that in mind. Next. And why we were looking at the Latino communities in the United States and why we wanted to go granular. Well, so as it was evidenced by preliminary analysis, Latinos were being hit very hard by the pandemic, not exclusively in terms of new cases and deaths, but also in the impact that the pandemic was having in their lives. They were getting pay cuts, they were losing their jobs, they were losing their homes. And those are factors that we need that we know are essential for our health and well-being. Next. Early in the pandemic, we also identified that we had some challenges associated with identifying race and ethnicity among those that were getting tested for COVID, and even among those who were hospitalized because of COVID complications. So we had very limited data related to race and ethnicity that could help us coming up with recommendations on how to address a pandemic in these groups. Next. And it was no surprise that for scientists that have been working in the HIV field for a while, that we could translate the knowledge that we had gained for nearly 4 decades of studying the HIV epidemic to address the issues affecting communities of color. Uh, as shown here in the work of Greg Millett, we have factors that continues to affect the HIV epidemic and are the same that we know are shaping the outcomes we're seeing with the COVID pandemic. And it's structural racism that have multiple pathways through other social determinants of health, such as income, home security, job or employment, insurance, incarceration, among others. And as previously shared by my colleagues, some of these structural factors have been incorporated to the AIDS-View resources, and they are available not only to cross-reference with HIV, also in our case was an inspiration to make the proper analysis and incorporate HIV data to our assessment. Next. And here is a general look without controlling for multiple sociostructural factors. We can see here how COVID pandemic is disproportionately affecting Hispanic, communities where there's more diverse, meaning that they have more people of color. We have less cases in predominantly white communities. And with that said, we wanted to control by other variables and see how was this really affecting communities of color, specifically Latino communities, and to get as close as we could to provide good information so actions could be taken. Next. So here are the data sources that we use for our analysis. Understanding the social and structural factors affecting COVID it was very complicated, it still is, but we could predict certain social behavioral factors like age or county population or where we had more Latinos, how many people had health insurance, also issues associated with housing, occupants per room, the language spoken by the community. We all knew that this characteristics in our communities were playing a role in terms of how we were outreaching, how the communities were getting information, and how they were using this information. So we also incorporated data from the CDC, the Census Bureau, the Bureau of Labor to monitor employment and other comorbidities, including diabetes, cardiovascular diseases, and HIV. And AIDS-View was an important source to get data relevant to HIV prevalence at the county level. That was the most granular information we could get for most of these data sources. And it was also consistent with providing information at the county level on how to address the challenges being presented by the COVID pandemic. And next. So here I'm presenting some of our findings. First in the map with orange in your screen, that's the distribution of Latinos in the United States at the county level. And as you can see, there is a significant proportion of Latinos in the Midwest and West of the United States, and also in the South, specifically in Florida, and in the Northeast. The maps that you have on your, next to that screen on more brownish color, that's the distribution of COVID cases per at the county level. The first map is the distribution of COVID infections in counties that were predominantly white. And then the second map illustrates infections in counties that are predominantly Latinos. And there, as you can see, there is an overlap where we have more Latinos, and also where we were seeing more cases affecting the Latino communities. And this was kind of a cross-reference to make sure that our study was heading in the right direction. Please note that in our study, we included Puerto Rico. And in AIDS View, you can find data on HIV and some of the social determinants of health that have been discussed so far relevant to Puerto Rico. And that's important because as a Puerto Rican and as someone who's conducting research in Puerto Rico, often we have challenges having access to data that is relevant to Puerto Rico, and also to cross-reference with other Latino populations in the United States. Next slide, please. So this slide is very similar to the previous one, but on this one we are highlighting where we were identifying more deaths among Latinos, and we confirmed that we were seeing more deaths among Latinos in predominantly Latino communities, and when compared to predominantly white counties, counties that were predominantly Latinos were reporting more cases. Next. And once we integrated the data on other social structural factors, we were able to build a story. And the narrative, unfortunately, was very consistent with our hypotheses. First of all, we looked at the data at the county level, but also we divided the United States in 4 regions, reflected of the diversity within the Latino communities. So when we look at the regional data using predominantly Latino counties, we identify that most cases in the Latino communities were reported in the Northeast and Midwest. Again, this is early in the pandemic. And we had more Spanish-speaking Latinos getting infected. We were also identifying that many Latinos who were employed were getting infected, and Latinos that had they were less able to stay socially distant were also an increased risk for infection. This is very consistent to what we saw early in the pandemic, and unfortunately we've seen on waves throughout the pandemic, Latinos who were in the front line, first responders, and in this case, as proposally I'm illustrating with this image, the meatpacking industry was also an area that it was described as essential during the pandemic, and therefore we also identify many cases because they were not implementing the proper measures to prevent new infections among workers. And next, we conducted a similar analysis to identify where we were seeing more deaths among predominantly Latino counties. And that was happening in the Midwest in particular, with Latinos that had crowded living conditions in counties with elevated air pollution, and counties that had less unemployment. So again, deaths were associated with having to continue working during the pandemic and not having the proper PPE and occupational safety. And crowded living conditions refers to housing, and the housing conditions in the Latino community is very common to see multi-generational housing. And that's why even today we're still talking and discussing with Latino communities about the need of using masks even when you're home, because some people are being able to stay at home, but others are going in and out because they need to continue working, and that could represent a risk for those who are staying home. Next. And we're seeing those disparities as we continue the evolve on the COVID pandemic. As you can see here, this is a map of my city, Washington, D.C. This is the first map is the HIV prevalence. And if you're familiar with DC, perhaps you understand all the maps and the words and the distribution of the different communities. But the first map, those that are in darker red are the communities that are also predominantly Latinos and of Black, basically communities of color. And to the left, with the lower prevalence is predominantly white communities. Look at what's happening with the COVID pandemic. Communities of color are also being disproportionately affected by the pandemic. And now that we started the vaccination, we are seeing the opposite, which is that predominantly white communities are getting more access to vaccine and getting vaccinated. And we can illustrate this using the data that is available through AIDSview. Next. And just to share some limitations of using data as the one in the way that I just showed it to you. Methodologically speaking, is not ideal. Sometimes we have to compile data from different sources that have different times history, but it's very practical, particularly if we are looking to make decisions, as previously shared by Dr. Berry. It's making use of data that is available, and that's so important. The association that we make at the county level does not necessarily reflect association at the individual level. And this is important depending on the kind of intervention that you are planning. I believe in structural interventions are the way to go to address these disparities. So the data at the county level is useful for structural interventions. And of course, the results are, in our case, are very specific to a date and time for the pandemic. And we've seen changes over the time. And that's just important to note. So thanks for the opportunity. Here is my contact information, and I hope that we have some time for Q&As.
Thank you, Carlos, and thank you, Kathleen. I think you all have both presented us with very practical applications of where social determinants of health data can be used for public health programming and policy, as well as for very timely research and applied more broadly to other infectious diseases, as Carlos has shown us with COVID-19. So I'm just going to wrap up our presentation by quickly highlighting some other health disparities and social determinants of health resources on AIDSview, and then we'll open it up for the Q&A. So first, I wanted to highlight our service locators, which include data on HIV prevention, testing, Ryan White care and PrEP services, as well as locations of housing opportunities for people with AIDS, and NIH-funded HIV prevention, vaccine, and treatment trial locations. These are all viewable on our interactive maps as service locators or overlays. We also have, as I mentioned, newly released HIV care continuum data that are included in our local data profiles at the city level. The continuum data include new HIV diagnoses, late HIV diagnoses, linkage to care, receipt of HIV care, and viral suppression. And all of these data can be stratified by age, sex, and race ethnicity. And you can review these data side by side along with our social determinants of health data. So here's just an example of the national profile. Again, you can do this at the local level, where you have a map of HIV prevalence on the left for the United States, and on the right, you can see the data stratified by demographics, as well as a summary of the social determinants of health data below that. And then in addition to the social determinants of health data and maps, AIDSview also has a new deeper look health disparities page, which we're excited about. So this page is dedicated to highlighting the importance of looking at disease burden through the lens of health disparities, sharing insights from those social determinants of health data. And we are also always interviewing HIV experts for different awareness days, for research that's ongoing, and really to share and disseminate the latest information about HIV and health disparities. The page features infographics, blogs by HIV experts, and we are constantly updating those pages. AIDSview has also really made an intentional commitment to providing more accurate data on transgender populations. So I just wanted to highlight here, in 2017, AIDSview released new data provided by 32 city jurisdictions across the US on the estimated number of transgender individuals living with and diagnosed with HIV as of 2015. So although the data that we have currently are limited, we really do think that they serve as a foundation and provide an important step towards improving our understanding of the burden of HIV among transgender populations, as well as informing how healthcare providers, advocates, policymakers can really better understand this particular population. So we really believe strongly that accurate data on transgender status is essential for us to be able to deliver more effective HIV prevention, treatment, and care services to transgender people. We also frequently have HIV and health disparities experts on AIDSview Q&A blogs, where experts discuss a variety of social determinants of health topics. Here are two recent AIDSview Q&As with Dr. Leandro Mina and Dr. Amy Justice. These are also available to download and share. And we've also developed social determinants of health infographics with the latest data. So I showed you this main summary page earlier, but again, I want to emphasize that these are also available to download and share for free. And then finally, just to reiterate, AIDSview really does provide these data for your use. So they don't live in a static form on the website. They are downloadable data sets available for HIV, social determinants of health. So again, that we are encouraging you all as researchers, health department, stakeholders, policymakers, et cetera, to use these data for your own analyses. And so all of these data can be found in the, again, in the tools and resources section under data sets. So with that, I'm gonna end the presentation and open it up. We have about 16 minutes for Q&A. And again, we look forward to hearing your questions and dialoguing with you.
Amanda, we had some questions that came through on the Q&A. Would you like me to read a few of them to you?
Yes, please. Thank you.
Great. What are some specific HIV disparities that might be linked to lack of states implementing Medicaid expansion? Might it have an impact on PrEP utilization?
That's a great question. I can start by answering it, and then please, Carlos and Kathleen, feel free to chime in. But we have used AIDSview to look at PrEP distribution, PrEP uptake, and have certainly seen that there is a strong correlation between Medicaid expansion or having something like a PrEP-DAP program and having PrEP uptake. So that's just one example of how we've been able to use the data to show where there are gaps in need. Dr. Aaron Siegler at Emory has created this PrEP to need ratio measure, which again kind of illustrates that where we have high rates of new HIV diagnoses, we're not seeing enough PrEP uptake. But Kathleen and Carlos, I don't know if you want to weigh in from your perspectives as well.
I think you've handled that perfectly.
I agree.
Great. Next question. Do you have rates of HIV testing at the census tract for the entire US?
Sorry, I'm just trying to get your questions up. Okay. So census tract data are available in many jurisdictions. Alicia, maybe you can help me with the exact number, but not all of our data are available at the census tract level.
Yeah, so zip code level is for about 45 cities, and then I believe it's about 3 cities are available at the census tract, and we're always looking to increase the level of granularity for our cities. So we continue to push that effort year after year and increase the number of cities and the number of, and the granularity. All right, next question. Thanks for the great presentation. Are there data available on AIDSview for people born outside of the US?
That's a great question. I see the Q&A now. We don't have data specifically on where people were born. Obviously if they're living in the United States, then we are including them. But certainly that would be interesting information to look at in terms of disparities around perhaps immigrant status or non-foreign born individuals. It's a great suggestion, something maybe we should look into further.
Great. Next question. Good afternoon. Is there any data that is related to retention and adherence? Retention, I believe that's supposed to be. Got it. Related to retention and adherence.
Yeah, so as I mentioned, we do have data on the HIV care continuum. Now, in general, we don't have data specifically on adherence. However, we do use viral suppression as a proxy for adherence. Again, with the caveat that, there is, in reality, there is a disconnect sometimes between actually being prescribed antiretroviral therapy and whether or not people take it. But our HIV care continuum would give you the best sense of starting from linkage and diagnosis to care to viral suppression.
Great. Kathleen, can you elaborate more on the patient bill of rights?
Oh, that's a good question. Yeah, it's basically going to be, information for folks so that it lists specifically that, if someone's living with HIV, that they have actually the right to get HIV care with regardless of their ability to pay or their status in terms of residency, etc. And things like that, and really some plain language information on where people, if they don't get those services, what they can do to make sure that they report that information and can get the appropriate services that they need. We're also going to have an LGBT specific Bill of Rights for those patients living with HIV as well. I don't know if people want any additional information. Those products are still in development. That may be something that we can share later on.
Thanks, Kathleen. What are some of the factors that may be leading to less PrEP use in the South?
Yeah, I see that question. So again, in this analysis that was done with Aaron Siegler and Patrick Sullivan, it was around PrEP use. It was very clear. I wish I could just pull up the slides and show you all. It was very clear that that there was less PrEP use in the South. Again, part of that may be due to Medicaid expansion. It may be due to other factors that weren't necessarily measured in our use of the PrEPview data, but things like distance to care, for example, could be a factor, and just limited access to the availability of HIV prevention services. I think we alluded to some of that earlier with the Medicaid uptake or Medicaid expansion, in the South, or lack thereof.
I would like to add that there may be some answers that we cannot give with the data that we can get through AIDSview. This could be a good example. We know that stigma, for example, mediates or is a factor in PrEP uptake. And it's very difficult to measure stigma. And so we don't have similar measures that we can add to all this mapping and analysis, but some qualitative work and more specific work in certain sections in the South is illustrating how social structural factors such as stigma, racism, and experiencing and embodying those experiences are also influencing PrEP uptake.
Thank you. Carlos, this one is for you. Carlos, you mentioned the disproportion of vaccines received by Latinx populations in DC. Is this due to those folks not being in the groups within the current phase of vaccine administration, or could other factors such as limited transportation, lack of technology in these populations have an impact?
Yeah, thanks for the question. So in our analysis, it's exclusively based on location, on zip code. And what we illustrated is that predominantly wards or community or sections of the city that are predominantly of people of color are underrepresented among those getting vaccinated. We know that there are several factors, and the city have made some changes to address those factors. For example, transportation is an issue. Having information available in Spanish, so people who are Spanish speaker can actually register to get the vaccine. And there is vaccine hesitancy in communities of color. And we are working on engaging more members of the community to support outreach and basically answer questions that our communities have regarding safety and trust with the vaccine.
And I would just add, thinking about this in the context of also social determinants of health, one of the things that's certainly here in DC is presenting another factor, in addition to all of those that Carlos mentioned, is just the lack of access to technology. And so, that's something that, again, is considered a social determinant, right? If we're living in a very virtual world and people don't have access to computers or laptops or even smartphones to be able to register for vaccines, it's not surprising that we see this disparity.
Looking through some of the other questions as well.
I can answer a question about collecting data in rural areas has been difficult. So we are collecting data from departments of health. Obviously our goal is to try to get as representative a sample of this data as possible. And that should include, depending on how the health departments are set up, it should include data from rural areas.
I see Patrick is typing a few answers as well. Perhaps this one next from Maria. What can be done to increase funding for the labs necessary prior to patients getting PrEP?
It's my understanding that you can actually, it depends on where you live, but if you're in an EHE funded jurisdiction, so that I believe some of the EHE CDC funds can be used for prevention, testing, and can support HIV testing and some of the other laboratories to start people on PrEP. It may not cover everything. But there's also, I think, in different states, PrEP programs that they may be looking at funding some of those activities. It's not usually that difficult to get patients the medications. The major cost for folks is really the labs and the patient visits.
Alicia, I see there's a question also here on data on comorbidities. So we do on AIDSview have data on hepatitis C. There's also data, if you look at some of the local profiles, on sexually transmitted infections as well. So there's HepView, and we would encourage you all to look at that page as well. But we know that, HIV is full of, many comorbidities, in addition, obviously, to these social determinants of health. But unfortunately, people who are living with HIV often are dealing with other chronic conditions as well as other infectious illnesses.
Oh, we got one last question. Will we add COVID to the comorbidities?
Yeah, I think that's a great question and very timely.
Please.
I defer to the AIDSview team, but I certainly, it's something, worth consideration given obviously how much of a focus it is right now. And as Carlos, very nicely pointed out, we know that these are syndemics. And so it's really important for us to look at the overlap and the relationship between HIV and these other infectious diseases, including COVID. And certainly a lot of lessons learned.
Thanks, everyone. Any last questions before we wrap up? I think that's the last of our questions.
Well, thank you, Alicia, for facilitating the Q&A. Again, I want to thank all of you all for your participation. I know that everyone is very busy these days, ever more so with COVID. And I, of course, want to thank my colleagues, Dr. Carlos Rodriguez-Diaz and Dr. Kathleen Brady, for taking the time to share their insights and their use of AIDSview data to address these social determinants of health. So thanks, everyone.
Thank you. Thank you, Amanda.